Welcome to the 2024 Pharmacy Press Conference. I am joined here with my colleagues, Senator Mann and Representative Bonner to the right and to the left, and others. And we have several pharmacists, patients, and public health advocates here as well. Today we're going to talk about the package of bills that are focused on protecting and strengthening access to patient health care in our pharmacies across Minnesota. Pharmacists are the most accessible health professional and provide critical health services to patients every day. They should be able to continue to provide essential services after the pandemic to serve patients, improve accessibility, and lower our health care costs. Americans average living just 5 miles from their pharmacy, and across that piece, and access to that pharmacy on an average 18 times per year, well, they may only see their primary care physician 1 time per year. However, many communities in rural and urban Minnesota have seen their pharmacies close in recent years, and the financial stability of many independent pharmacists in Minnesota is dire, not good. Our legislation that you look at today, Senate File 1176 and the other body, House File 1197, seek to continue patient-administered vaccines in point-of-care testing at a pharmacy. Without it, members, families and patients will see access to these critical services go away. And why is this important? In 2020, the federal government recognized the vast resource pharmacists are in a fight to make sure Americans were vaccinated for COVID and other diseases. And under that emergency declaration in 2020 of the Public Readiness and Emergency Preparedness Act, otherwise known as the PrEP Act, you'll hear that, the Secretary of Health and Human Services provided pharmacists, pharmacy technicians, and pharmacy interns across America with the authority to do 2 things: vaccinate patients ages 3 years and above with any FDA-approved or approved for emergency use vaccine. Number 2 is to order and administer and interpret FDA-approved or approved for emergency use, the CLIA waiver tests, so there's non-laboratory testing like influenza, strep A, HIV, and A1C. This bill ensures that patients that have access to the immunization services can and will continue at their community pharmacy now and after this pandemic is over. This service allows for the screening and treatment process to be completed during a single encounter. Thereby, that improves access to care, counseling, that's the key thing, and patient outcomes. Without legislative action, many of these services will end when the PrEP Act expires at the end of this year. Minnesota pharmacists delivered for patients over the past 4 years by vaccinating millions of Minnesotans. Without them and their pharmacy technicians, Minnesota could not have inoculated against the COVID-19 pandemic. And we need them. And patients in Minnesota expect to be able to receive their vaccinations and healthcare testing in a Minnesota community pharmacy, your neighborhood pharmacist. Now I want to hand it over to our co-author in the House, Representative Bonner, and also Senator Mann. And with that, thank you for being here today.
All right. Good morning, and thank you for being here today. I am State Representative Kristen Bonner, representing the lovely community of Maple Grove. I am the daughter of a nurse and grew up with a pharmacist next door. You can imagine that led to some lively conversations over the fence and around the dinner table. The bill Senator Hoffman and I introduced has made it through all of its relevant committee stops. The bill is a priority this year, and I want to stress this, as some of the permissions granted to pharmacists and pharmacy techs since 2020 are set to expire at the end of the year. The bill before you is simple. It ensures that fully credentialed, trained pharmacists, supervised pharmacy technicians, and pharmacy interns, who are an essential part of the care continuum, may continue to perform basic immunizations and testing services in the pharmacy setting, as they have throughout the pandemic and are currently providing for Minnesota patients and families. I'm here today to enlist your support for the continuation of an incredible story. During the pandemic, Minnesota pharmacists, pharmacy technicians, and pharmacy interns were able to vaccinate and test millions of Minnesotans. In 2020, federal authorities turned to pharmacists pharmacy techs to get shots in arms, and they delivered. While doctors and clinicians continue to make the case that they cannot do this work alone, they continue to agree that pharmacies are an essential part of filling this gap. As you know, local pharmacies form the cornerstone of our communities, with many patients seeing their pharmacist more frequently than their healthcare provider, forming a significant level of trust. Ultimately, providing services in the pharmacy as part of the care continuum means lower costs for patients and payers, and most importantly, we ensure better patient care and outcome for patients in both rural and urban settings across the state. As these fully credentialed pharmacists and pharmacy technicians provide essential services that patients need in a setting they know and trust, it just makes sense that they should be paid for the services they provide in our communities. But to make that a reality, pharmacies need to be in our community to provide these services. And that means they need a financially stable, and they need to be in businesses where the economic model works. And currently, in some forms, it does not. Which is why Senator Mann and I introduced 3 bills to help ensure the economic viability of pharmacies so they can continue to do this good work with patients and within their communities. And with that, I will hand it over to Senator and Dr. Mann to discuss our bills and to provide a cost reimbursement for Minnesota MA patient care and medications, as well as bills to guarantee that pharmacy services will be covered by patients and insurance.
Good morning, everyone. Thank you, everyone, for being here. I'm Senator Elise Mann. I represent Bloomington and Edina. I want to thank Representative Bonner and Senator Hoffman for all the work that you're doing on the behalf of patients in Minnesota. The incredible work that has been done over the last several years in our community pharmacies has already been mentioned, and so I'm not going to go over that again, but I do want to say that as a physician, I see every single day the incredible work that our pharmacy colleagues are doing, and I know that without them in this fight, I do believe that Minnesota public health is at risk. A trusted pharmacist is an essential piece of the healthcare team for patients, and by having pharmacies and pharmacists as partners in patient care and treatment, we provide patients across Minnesota access and convenience that they need for their care. We know that in rural Minnesota, many people do not have multiple pharmacies to choose from. And the fact that pharmacies all over Minnesota are closing is very, very alarming. Since 2018, Minnesota has seen almost 35% of independently owned pharmacies close and 20% of chain pharmacies close. In the last year, 24 community pharmacies have closed in Minnesota, and 4 more have already closed in the first quarter of 2024. You will hear from some of our pharmacy owners next, and many of them will tell you that they can't survive through 2024 at the rate that they are going with the inadequate reimbursement that they are receiving. And that's why we have introduced this important legislation that will provide close to at-cost reimbursement for pharmacy health services and reimbursement for cost of the prescription medications they provide. Passing these bills will go a long way in helping the financial stability of our community pharmacies. So briefly going over the 3 bills introduced, we have Senate File 2459 that would ensure that pharmacists and pharmacies are being reimbursed for the services that they provide. Pharmacists are trained to perform many of the same health services as other healthcare providers, but are not reimbursed at the same rate, if at all. We have Senate File 5123, which will establish a direct dispensing reimbursement payment model to certain qualifying rural, underserved, and independently owned pharmacies. There have been more pharmacy closures in Minnesota in the past 5 years than any other state in America. And this bill will establish a direct dispensing payment program for pharmacies that will seek to address the currently unsustainable reimbursement to pharmacies by the pharmacy benefit managers, or the PBMs. And in the next year, we will also address the unethical practices of PBMs, so stay tuned for that. Lastly, Senate File 3971 will update the current professional dispensing fee from $10.77 to $11.55. This is the fee-for-service reimbursement rate that if we don't update, pharmacies can't provide the services that they provide. This increase was a recommendation from the cost of dispensing survey done by DHS in August of 2023. So those are the three bills that we need to seriously consider if we are going to keep more community pharmacies from shutting their doors and leaving more pharmacy deserts in Minnesota. We know that currently rural and urban pharmacy deserts are growing in Minnesota. For example, there is currently no pharmacy within northern Minneapolis and several neighborhoods throughout St. Paul. So the time for action is, well, a long time ago. We are well overdue for action. Senator Hoffman and I do have to go back to caucus. We have a floor session we need to get to, but I'm going to leave you guys in the very capable hands of our pharmacists and our patients. So at that, thanks again.
Good morning, and thank you to our legislative authors and pharmacy supporters. I couldn't have explained the importance of these bills any better myself. And the importance not only to our patients in Minnesota, but also to the economic health of our pharmacy community. My name is Jason Miller. I'm Clinical Program Manager for Coburn's and Cashwise Pharmacies. Also the co-chair of the Public Affairs Committee for Minnesota Pharmacists Association. And I'm here today on behalf of the Minnesota Pharmacy Alliance. So the MPA is made up of stakeholders from Minnesota Pharmacists Association, the Minnesota Society of Health System Pharmacists, and the University of Minnesota's College of Pharmacy. Representing the interests of pharmacists across a broad spectrum of practices, we are all united in the pursuit of a fair and sustainable economic model that will stop this epidemic of pharmacy closures and allow us to keep our pharmacy services available for Minnesotans and communities everywhere throughout the state. And I do know that patients absolutely want these services provided in their community by pharmacists that they know and trust. I've been a part of and witnessed the remarkable job that my colleagues have performed through the pandemic and continue to perform day in and day out in your local communities. So on behalf of community pharmacies, our provider colleagues, and access to critical patient care in Minnesota, I ask you to pass these bills that will maintain continued health and wellness services for Minnesotan residents. And that's really it for me. I'll be around for questions afterwards, but I do want to hand it over to some patients who probably have more important things to share with you, to give some testimonials, and then we'll wrap up with remarks from some of our independent pharmacist owner colleagues. Thank you.
Hi, my name is Dave Little, D-A-V-I-D-L-I-T-T-L-E, and I am a happy and pleased patient at St. Paul Corner Drug in the Mac Groveland area, and I've been there through 3 different ownership iterations for over 40 years, and I would hate to see them close. Last year I found out that they were losing money on filling my prescriptions for brand name drugs, including for eye drops for glaucoma medication and a blood thinner to prevent strokes, and they couldn't fill them anymore for me. And so I went with Express Scripts, traditional mail order pharmacy that works with my insurance. And I can tell you that, in short, my pharmacy experience with Express Scripts has been tough. They have illogical policies, unnecessary hoop jumping, poor communication, and a kind of a glitchy website. And it puts all the burden on the patient who, you know, at my age, you start losing a little bit of your ability to jump through hoops. So I've been relying on a nurse and family members to help make sure that I get my medications, I get the correct medications, because we've had a problem with that through mail order, getting the wrong drugs. And that was an experience that my pharmacist at St. Paul Corner told me is one of the best outright examples of unsafe pharmacy practices that they've come across so far. And that's why I'm here to mention it. Unfortunately, I've talked to other patients like myself who have had some pretty strange experiences going through mail-order pharmacies. So I want to emphasize, we need our community-based independent pharmacies that care about us, know us as people, and not just to fill a prescription. They know what we need, they know what, how our prescriptions might delete certain vitamins or create certain needs in our bodies and can address that for us. And we don't usually hear that anywhere else. They save lives, try to keep us healthy, and they're closing faster than ever before because of practices that the state of Minnesota has not protected independents from, including practices by PBMs who act as middlemen. So that's my statement, my story, and there's more to come.
Hello, I am Cindy Harley, Cindy Harley, and I am also a proud patient of St. Paul Corner Drug. I suffer from debilitating migraines, which their team has been absolutely critical in helping me manage. And to make my migraines more fun, periodically my treatment stops working, and I need to find a new one that works. The last time this happened, I stopped by the pharmacy to pick up a new migraine medication. The one I'd been on previously. So basically, I had to have 4 treatments not work to get a medication that we knew was very likely to work. This was one of those in that series. The pharmacist on duty recognized the medication and asked if I had migraines. When I said yes, they suggested some nutritional supplements to accompany it, and then handed me a summary of the scientific literature about the supplements and their efficacy in treating migraines. I'm a biology professor, so they got bonus points from me. I had been on similar supplements, but I didn't know that the formulation mattered. I didn't know it made them not bioavailable. And so the versions that St. Paul Corner Drug carries were able to actually get into my bloodstream, and they were able to explain to me why the formulation mattered. No one in my doctor's office told me this. They just said, take some magnesium, it'll make you feel better. I still picked up my prescription for Topamax, the new migraine treatment, and I'm beyond thankful that my pharmacist educated me about the potential side effects of the medication, including brain fog and depression. This is because weeks later, when I found myself unable to think or function and wondering if I was even smart enough to work anymore, I suddenly remembered that my pharmacist had mentioned these side effects. Because of this, I was able to have my physician intervene, and I was able to change my prescription. In times like this, when I can't think as clearly as I would like, and I'm in a lot of pain, I appreciate more than ever being treated like a human and not just a number on a bottle. To me, this is what an independent pharmacy does for its patients and why it's so important to keep it alive and accessible. However, my story doesn't stop there. We did eventually find a migraine treatment that worked. However, due to PBM abuse within the industry, St. Paul Corner Drug was losing money filling the prescription. I've had to opt to going to CVS Caremark to fill the medication. Since then, I've jumped through numerous hoops, including a crucial mistake by CVS Caremark, where they shipped my medication without knowledge that it had to be refrigerated, rendering it inactive. This kind of low-quality service has never happened at St. Paul Corner Drug. For example, when I've forgotten to pick up my prescription, I've gotten a courtesy call asking, "Are you struggling to get your medication? Can we help you?" This is how you treat patients. You make what they need accessible. You help them care for themselves. You help them navigate a broken system. In addition, this small but mighty independent pharmacy has done so much more for our community, including holding vaccines at clinics at my son's schools, delivering medications during COVID when it was not safe to go to the pharmacy, and for the longest time, their soda fountain has been a gathering place for elderly and children alike. As a patient whose health and quality of life directly depends on my local independent pharmacy, what needs to be done is clear. Pass these bills in order to keep locally based pharmacies alive and accessible, and follow that with further legislative reform and accountability for the entities that underpay or even take money away from them caring for patients. Without them, patients like me will be harmed or even die living in pharmacy deserts. Thank you.
Those are powerful stories. My name is Deborah Keaveney, Keaveny. I'm a pharmacist and owner of Keaveney Drug in Winstead. I'm also the founder of the Minnesota Independent Pharmacist Coalition, also known as Mindy's. Many of our members are here today representing what's left of the state's independent pharmacy population to show support for patient access to their local pharmacies. At one time, Minnesota was fortunate enough to have an abundance of independent pharmacies. We are now down to less than 108 independents and continuing to lose some every month. The National Community of Pharmacy Association conducted a study last year which projected the U.S. would lose as many as 30% of small business pharmacies by the end of 2024. If Minnesota follows that trajectory, we're looking at nearly 40 pharmacies closing in the next 8 months. When a pharmacy closes, it means a patient has to find another way to get their medication, their immunizations, their care. It could mean medication by mail, which we heard a story on, or driving as far as 50 miles to the next town. Mail order pharmacy is risky in a state where winter temperatures reach extreme lows, and driving in winter conditions can be treacherous. Some patients will try to avert that risk by either rationing their medications or stopping their medications altogether. While we're also grateful for Governor Walz and the state legislature for passing 62W, that was the Pharmacy Benefit Manager Transparency Act. It was a great piece of legislation. It really is not enough, so it, along with these bills, will need to be strengthened. Like the rest of the locally owned small business pharmacies in our state, my pharmacy cannot remain open for long without the partnership of the state legislature, the governor, and the enforcement arm of our Department of Commerce. We need relief, beginning with stopping the forced underwater reimbursements and passing these bills to protect pharmacy services. Our patients and their access to affordable, quality health care depends on it. Thank you.
My name is John Hessian. I'm the proud owner of St. Paul Corner Drug, and I've practiced community pharmacy at that site for the last 35 years. I want to give one final thank you to our representatives and senators who have brought these bills forward, Senator Hoffman and Senator Mann, and also Representative Bonner, for supporting these bills and standing alongside us today with unwavering support for the preservation of community pharmacy in Minnesota. Today, I urge the Minnesota legislature to support these bills aimed at sustaining and advancing our local pharmacies. These community institutions are not just businesses. They are vital lifelines that provide essential healthcare services and contribute to the fabric of our neighborhoods and larger communities. First and foremost, supporting legislation to sustain local pharmacies is about preserving critical access to quality healthcare. In many areas, especially rural and underserved urban communities, local pharmacies are a primary and sometimes the only source of immediately accessible medical care for residents. And even when they're not, we commonly are the providers that sees or interacts with our patients more than their primary care provider, specialists, or other therapists. Legislation that supports local pharmacies ensures that individuals, regardless of their location, socioeconomic status, or other defining demographics, have access to the medications and healthcare services they need to thrive. Minnesota community pharmacies have a diagnosis: terminal illness. Ongoing below-cost reimbursement for services rendered and the financial hardships that result are the symptoms of this disease, which have resulted in alarming closures across the state, leaving areas of rural and underserved neighborhoods in the metro area without access to pharmacy services. These services include essential medications, vaccines, point-of-care testing, healthcare supplies, and the professional guidance that community pharmacists provide to their patients. It is so much more than pills in the bottle. Like most health-related conditions, there are various root cause issues contributing to this disease, which without intervention will certainly lead to the closing of most, if not all, community-based pharmacies in our state. We have been working tirelessly to address these issues over the past 2 decades, and through no fault of our own, have only achieved very limited success. Today, we find ourselves hoping and praying for any sort of lifeline to sustain us until we achieve fundamental reforms in the way that our services are delivered and how we are compensated for them. Like an emergency antibiotic, these bills are the prescription we need right now. The lifeline that will buy us time to engage in a treatment plan to help ensure that local pharmacies will be able to continue serving their communities for generations to come. This legislation will provide much-needed immediate financial support and the ability to get paid appropriately for the services we provide to our patients while we pursue more comprehensive reform. Let us stand together to preserve these vital institutions. Let us support legislation that recognizes the unique role of local pharmacies as essential members of patients' healthcare team and empowers them to continue their mission of providing compassionate care and exceptional service to all. Let us put patients and providers before profit and put our state on the right path to addressing our nation's worsening health and therefore human rights crises. Thank you.
With that, we have time for a few questions, if any reporters.
Are the reimbursement rates set by the PBMs, or is it Medicaid, Medicare, or what's the driving force in squeezing the, all the revenue out of this?
Pharmacies contract with pharmacy benefit managers. Pharmacy benefit managers set the price that we reimburse. They also choose what drugs are on the formulary. Unfortunately, we can't really call these contracts or agreements because it's basically you take it or you leave it. So our choices are, if you don't accept a contract from one of the big 3 PBMs, you're saying goodbye to 1/3 of your patients. 1/3 of your patients are going to have to go somewhere else. So the pharmacy benefit managers are in the driver's seat. They are causing this, and they are the problem.
Are they the ones that are dictating, like for example, Mr. Little, moving to a online pharmacy, or are they just saying we're not gonna pay for this drug anymore unless you buy it online?
It's a combination of things. Many times they steer our patients away. I call stealing. They'll send letters out and tell patients, you can't go to, Kevin E. Drug in Winsted anymore because they're not a preferred pharmacy. So if you want to use your pharmacy benefit card, you must go to a CVS mail order, a CVS, Walgreens. I mean, they all have their little innuendos.
In the situation like Mr. Little with his medication, we could continue to fill it and bill it through the PBM contract, but we lose so much money that what would happen is we would ultimately close and not too far in the future, and then we wouldn't be there to serve anyone. And so it's kind of a hybrid model where we're working with patients to get those things that we lose on a lot of money on from a different source. And one of those is their mail order option, so that we can still stay in the community and continue to serve patients. Because if we're taking a $50, $60, $70, $100 loss on a one prescription, there's no way we're gonna be there. It's just that model doesn't work in any business.
Can someone elaborate more on the Federal PrEP Act expiring and how so this says that the Emergency Act gave pharmacists the authority to vaccinate in this pandemic. Is that to say that without this, pharmacists cannot do vaccinations anymore, so somebody has to go to their primary care doctor?
So what the PrEP Act did in Minnesota, at least, was expand some of the pharmacist authorities to vaccinate. So prior to the PrEP Act in 2020, pharmacists could vaccinate to ages 6 and up for flu, 13 and up for non-flu. With that PrEP expansion, it also allowed pharmacy technicians to vaccinate, which was new for our state, and then expanded the age range down to ages 3 and up for all vaccines. So now we've kind of adapted some state law, and our current legislation that's introduced is 6 and up for all vaccines.
So it would just be kind of taking that federal law and making it a state law?
Yep, correct, yeah. So without that passing, we would take a significant step backwards in terms of access to care for residents of Minnesota. We saw this past flu and COVID season how many small pediatrician offices did not even stock COVID vaccine due to it being commercialized and having a really high cost, not great returnability, and unknown demand. So they just weren't willing to take on that risk. And so there was a segment of patients that weren't able to get vaccinated in their pharmacy. We had pharmacists that worked for us that couldn't take their own kids to our own pharmacies to get vaccinated. So it's, again, it's a flawed system. So this looks to correct that a little bit and just make access to care better for everyone.
That was an emergency measure designed to increase access to COVID vaccine. Do you even want that additional care providing responsibility? You've got enough on your hands filling meds.
That is a really great question. The answer to that is yes. And so pharmacists are healthcare providers, so that's what their job is. We try and keep people well, right? Vaccinations are just one way to do that. The reimbursement goes hand in hand with that, though. So for so long, pharmacists have advocated to get more authorities to do more things. And now we have them, well, we need to be paid as such. And there's a gap there in the healthcare system. So the ability for primary care providers and clinics, all faced with staffing shortages just like everyone else, there is a need there for the healthcare system for pharmacists to be able to provide those services.
As a quick follow-up, implied in this then is that if the PrEP Act ends and there's no state action, you won't get paid for this service. Will the pharmacies be forced to stop doing it, or will they just kind of dig deep and figure out a way to pay for it on their own?
Well, some of it is legal, so the actual ability for us to provide those vaccinations to those patients at that age range, that would take a step backwards, so there would be less access to care for patients, but then also for pharmacy providers, so there's just less ability to provide those services. It's a smaller targeted group, right? And then some of the other legislative pieces look to increase reimbursement. So the simple reimbursement for actually filling a prescription. So the data for the cost of dispensing survey now is almost 3 years old. Well, we've seen record inflation everywhere. Pharmacies, not been immune to that as well. And so now we're looking at 3-year-old data that, already says we're about $1 per fill underwater on. It's in reality probably more than that. So the economic packages are just as important as the clinical service ones too.
Would the reimbursement part mean the state fills in the gap with state money, or that the state requires the insurers to pay the full price?
Actually, both. There's two bills. One is the fee for service. We always call it straight Medicaid in the health professions. Just the cost of dispensing. So each time we fill a prescription, it's behind $1. So currently, on those fills, we need to get that increased up to 2020 market rates. The other bill, the directed pharmacy payment one, would be the state mandating to all their health plans that service Medicaid members that an additional monetary amount yet to be determined would be added to help pharmacies stay whole.
Is the formulary kind of a moving target? Meaning that it's
Yes.
flux?
The question is the formulary a moving target? It is. Their 62W, I believe, had some language in it that would require notification of formulary changes and things of that nature. But again, Deb mentioned how 62W and Senator Mann mentioned as well. Needs some work. It needs a little bit more teeth behind it. So we did institute this law 3+ years ago now, and we found it's just very difficult to isolate specific claims and to sort of police them, I guess. And so the formulary changes, again, this gets really, really nuanced and difficult to get there because we have pharmacist peers that work for those health plans, right? So they're not entirely the bad guy that we kind of make them out to be, but their influence has probably tipped too far in one direction. So a formulary change is intended, there's clinicians that help guide those decisions, right, to make sure that medications that are used to treat conditions are available and are affordable, right? Everybody, there's only limited amount of dollars to go around, right? So they're trying to limit costs, but like I said, it's shifted too far in one end of the spectrum, and it's put our pharmacy model at risk and patients' access to care at risk.
This is kind of an off-topic, but have any of you been affected by the Change Healthcare data breach?
Question around the Change Healthcare data breach, yes. You want to take that one, John? Yeah, go ahead.
Yeah, I mean, you know, it's everything I've seen and heard, it's played off as not that big of a deal. I've got a stack of paper. I mean, for my pharmacy, we were using a different switch than Change. But a year ago, if this had happened a year ago, all of our claims are going through Change Healthcare. So the initial impact to us was not as much as a lot of other providers who are using Change as their primary switch. Where it affects me is billing Medicare B claims, and that's primarily individuals that are on Medicare that are getting like COVID, flu, pneumonia shots, that kind of thing. So at this point in time, I have not been able to bill any of those since February 21st date of incident. And, you know, it's just a stack of paper that's growing every day. I mean, I'll go back and add another 8, 10 to it this afternoon when I vaccinate some more. But I mean, each one of those pages is worth about $185 to me. And so, you know, it's thousands and thousands of dollars already that I've accumulated and accrued that I haven't been able to get paid for. And so if you can't bill a claim, you can't get paid for a claim. And that's where we all find ourselves, is that if it's a claim that has to go through Change Healthcare to get to its payer, then that claim is just in limbo land right now. And to my knowledge, I mean, there is no date of fixing this. And so we don't know how long that's going to go on.
So, are you finding a lot more multi-state companies are requiring their employees to go through a certain pharmacy? Like my company 20 years ago said we have to go through CVS to get coverage for pharmaceuticals. Is that an issue where you're seeing more of that happen?
Yeah, I mean, when you're talking about, and this is where our lack of power comes from, is that, you know, if Blue Cross Blue Shield decides that they're going to use Prime Therapeutics as their benefit manager, as their PBM, then if we can't work out a reasonable deal with Prime Therapeutics, we basically don't have access to any Blue Cross patients. So it's like we're being held hostage to accept those rates, or we give that patient up entirely. Now, many of us have figured out ways around that. With most, you know, like 90% of what we dispense is generic drugs, and most of them are relatively inexpensive. So, I mean, we're doing a lot of self-pay. You know, patients, they want us to be there. They don't want us to close. They know the situation we're in regards to dealing with the PBMs and the reasons why we couldn't agree to contracts that are so far underwater that we wouldn't make it to Memorial Day. You know, and so they're just deciding to self-pay a fair price, and that's all we're asking for. We're not asking to wheel, you know, barrels full of gold out the front door every day. But I mean, we do need to be made whole on the cost of the drugs and the cost of what it takes to put it together and service the patient. And right now, about 60% of what we dispense in my pharmacy is below water. 60% of what we do is below water. 40% of it is grossly below water. But I mean, that is not a business model of sustainability. If this continues, we will not be there. Doesn't matter that it's been there 102 years. Doesn't matter that we all care. Doesn't matter that we show up every day and bust our butts to take care of patients. The money doesn't work, the business closes. End of story.
Did I hear you just say that these legislative efforts are kind of Band-Aids to get you through, or are these meaningful reforms for the long term? How would you describe it?
Well, some of it is more permanent stuff, like changing the Medicaid dispensing rate for the fee-for-service part. Currently, we're being paid on 2017 data. The cost of dispensing in 2017 is what the current rate is. We did a cost of dispensing study in late 22. The data was collected, but it was 2021 data. So the new proposed number is based on 2021 data. Well, anybody understand what happened to inflation since 2021? I mean, even if we get the legislature to pass and write into law the new dispensing rate for fee-for-service Medicaid, it's still probably another $1.50 behind where it should be in 2024. So, I mean, it's imperative that we get that done, so at least we get the change from 2017 to 2021. I mean, because it just doesn't work. The math doesn't work. And so, so that's about 15% of the Medicaid patients in Minnesota have that type of coverage. The other side of that, which is more of a, as you said, Band-Aid, would be the part that goes through the managed care organizations and the PBM paid claims, which is about 85% of the Medicaid recipients in Minnesota have that type of coverage. So what that bill would do is to temporarily add an extra fee for independent pharmacies and underserved community pharmacies so that we can keep our doors open. That is going to require some substantive foundational change for that to go away. And that is, things that we will be working on during the off session time of this year so that we're ready to introduce some legislation into the 2025, which is a budgeting year session, and actually get some foundational change so that pharmacies can be made whole servicing all Medicaid recipients.
I can add a little piece of that too. So the reference of a Band-Aid this is a lifeline. This is pharmacy reaching out to our legislation and our public saying we need help to continue to exist. Our EMS brethren were here at the Capitol a couple months ago telling the same story. So it's the healthcare system in general that's, someone said it's broken. It's a system, it's not broken. It does exactly what it's intended to do. It's an economic system. Somebody's making a lot of money. It's not the providers. We can't fix that today. That's too big a problem to address. What we can do is try and pass these bills to make pharmacy services continue to be available in Minnesota, so.
Time for one more reporter question?
I would just add, 26% of Minnesota's population gets their health care through Medicaid, paid by the state, and that's why, just another little fact. It's about 1.5 million Minnesotans.
Perfect. Thank you all.
Thank you.